Hi, I'm Dr. Henry Black. I'm a clinical professor of internal medicine at the New York University School of Medicine and president of the American Society of Hypertension. Isolated systolic hypertension has been an interest of mine for entirely too long, it seems. I was a participant in the systolic hypertension in the elderly program when I was at Yale, and we showed without question that individuals with stage 2 isolated systolic hypertension, more than 160 and less than 90, over the age of 55, would benefit from pharmacologic treatment. We began with chlorthalidone, added atenolol if needed compared to placebo, and had a very clear result. We reduced strokes by about 40%, heart failure by about 50%. But one thing that isn't clear is whether or not isolated systolic hypertension is a precursor of heart failure. We showed that we could reduce its incidence by treatment, but we haven't shown that it's really related. And in order to do this, investigators at the University of Alabama took the cardiovascular health study data, which is publicly available, about 5,800 volunteers who were just observed observationally, to see if they could find a relationship. They looked at some of these individuals who had heart failure compared to those who didn't, and were able to show that especially for chronic kidney disease, for diabetes, and for impaired glucose tolerance, that there was a clear relationship between heart failure and the development of isolated systolic hypertension and the development of heart failure. Problem is, it's so confounded. There's statin use, there's blood pressure use, there's weight, there's waist circumference. I can go on. So they tried a new statistical trick, at least new to most of us, called propensity analysis, where what they did is look at all the risk factors they thought might be explaining the development of heart failure. Heart failure happened in 22% of those with isolated systolic hypertension, compared to about 16% of those who didn't have it, to see whether the confounders could explain that and whether it wasn't the blood pressure at all, or at least the presence of isolated systolic hypertension, high systolic, diastolic less than 90. Now what a propensity analysis does is to try to match pairs, people with the same age, the same level of blood pressure, the same cholesterol, and come up with a way to analyze this. It's a very interesting technique. And again, it's an attempt to learn something from data beyond what a randomized clinical trial can teach us. Well, this group identified 64 potential confounders, 64. And the list is long. It includes just about everything you could think of. And they even figured out a way to deal with an unexpected confounder. We do clinical trials to avoid bias, things that we can't think of. And sometimes we just can't do a trial that would be the same thing, so we have to use other techniques. Well, using this propensity analysis, they were able to show that for each millimeter increase in systolic pressure, the incidence of heart failure went up 1% as well. And this was highly statistically significant, although it wasn't a great increase. They also showed that about 16% of people who developed heart failure couldn't be explained by what they looked at, the various other risk factors, so it was an independent contributor, as opposed to 14% who didn't develop heart failure. This too is significant for stroke, for heart failure, but not for MI or for all-cause mortality. So I think we can now add, safely at least, that heart failure is another consequence of isolated systolic hypertension, which means that we got to start thinking about treating people with isolated systolic hypertension aggressively before they develop heart failure, the way we did in CHEP, later confirmed by CystEUR and CystChina. So as we're aging, as our systolic rises and our diastolic falls, this is going to become an increasing problem. Heart failure mortality is enormous. Most of it these days we think is due to hypertension and probably to isolated systolic hypertension in particular. So thanks very much for your attention.